Thank you. Very good evening to all of you. And I, on behalf of the Indian Society Cornea and Cataract Refractive Surgeons, welcome you all in this webinar on challenging cataract cases. And we have our President ISCRS, Professor J.S. Tityal, with us. Unfortunately, he's traveling, so he may be joining partly in bits and pieces whenever he gets the proper network. Then we'll shortly be joined by our Vice President, ISCRS, Dr. Rishi Mohan. We have with us our Chairperson, Scientific Committee, Professor Namrata Sharma, who is also the Professor of Ophthalmology and Cornea, Cataract and Refractive Surgery Services at RP Center, AIMS, and of course, the Secretary of AIOS. We also have with us Dr. Rajiv Mukherjee, who is the Treasurer of ISCRS and Director and Senior Consultant, Mukherjee Eye Clinic, New Delhi. We have with us as speaker Dr. Deepak Migur, who is a cataract and glaucoma expert and works at Migur Eye Care at Bidar, Karnataka. We also have with us Dr. Sartaj Grewal, a young Turk who is very dynamic consultant at the Cataract and Refractive Surgery Services at Grewal Eye Institute, Chandigarh. We will be joined shortly by Dr. Sonu Goyal, who is Director, Anand Hospital and Eye Center, Jaipur, Rajasthan, and Dr. Ratish Chandra Paul, who is Chairman, Sushrut Eye Foundation and Research Center, Kolkata. We also have with us Dr. Anand Parthasarathy, Medical Director and Chief Surgeon, Center for Vision and Eye Surgery, Chennai, Tamil Nadu. And we also have with us Dr. Love Kochigave, Director, BBI Foundation, VIP, and Netralayam Eye Care Center, Private Limited, Kolkata. Ma'am, can you?
Yes. So I think it's a great program today, and we welcome you on behalf of the Indian Society for Cornea and Cataract Refractive Surgeons. And I think without much ado,
No. Ma'am, the rest of the
Dr. Amiya Kulkarni, who's the consultant of Dr. Anil Kulkarni Eye Hospital, Miraj, and Dr. Rajesh Agarwal, who's consultant at Ashrafi Devi Eye Hospital, Hyderabad. We welcome you here and we look forward to your talks.
Ma'am.
Dr. D.B. Roy Chaudhary, Senior Consultant from Avishkara Netralaya, Kanpur, and Dr. Tejas Mehta from Shri Gurudev Netra Chikitsalaya, Agrasen Choraha, Indore. We again welcome you and look forward to hearing from you. Dr. Prasann Kumar, Director, Nirmala Eye Clinic from Jharkhand, and Dr. Bharti Gupta, Director of Bharti Gupta Eye Care Center from Faridabad. Then we have Dr. Jatinder Vahi, Consultant from Greens Medical Center, Lucknow, and Dr. P. Ellen Kumaran, Medical Director from Navshakti Netralaya, Bengaluru. Navshakti Netralaya, Bengaluru. And of course, we have our very dynamic Secretary of the ISCRS, Professor Rajesh Sinha, who's the consultant at Cornea, Cataract and Refractive Surgery Services at All India Institute of Medical Sciences, New Delhi.
So thank you, ma'am, and thank you all of you. Thanks to all of you for joining in. And shall we begin the scientific proceedings, ma'am?
Yeah, I think we can start.
Okay. So we have the first speaker, Dr. Deepak Migur, who will be showing his wonderful video on
Good evening, everybody. Thank you for the opportunity, Dr. Rajesh, Dr. Namrata. Very happy to be here. Is my screen visible?
Yeah, it's visible.
Yes. Okay. So I'll be speaking on partially absorbed cataracts or membranous cataracts. And this was a topic given to me by Dr. Rajesh. And let me take you through a couple of cases here. This is a 23-year-old gentleman who has a long-standing traumatic cataract and injury sustained 13 years back. And when I examine in slit lamp, there is a loss of convexity of the anterior capsule. This could probably an indirect hint that we have an, apart from being an absorbed cataract, possibility of a pre-existing posterior capsular tear also. It is a membranous cataract. And there are a few challenges which we are going to face while dealing with such cataracts. And one of the thing is the dealing with the fibrotic anterior capsule. And these capsules are extremely difficult to cut, difficult to tear. They sometimes will be flimsy, sometimes will be extremely tough to cut. And after trying with all the scissors, forceps, needle, ultimately I would want to just trying to make a small opening and then try to cheese out the subcapsular fibrosis if at all it is possible. I'm trying to create some space by injecting OVD, but ultimately it's very difficult for me to use the traditional instruments to deal with this sort of a capsule. So my last resort in such situations is or the best tool I would say is to use a vitrector. I'm using a vitrectomy cutter, it's a 23G cutter, and I'm using in an irrigation, aspiration, and cut mode, and just to eat out all the, I'm creating a rexus using the vitrector itself. I'm just holding it with a bevel up and then trimming the anterocapsular opening. The beauty of this device is that you can cut the membranous capsule, fibrotic capsule, without causing any stress on the zonule. At this stage, I think the PC tear is there. I'm noticing that because the anterior capsule and the posterior capsule were fused at some portions. And invariably, the dye also has escaped behind. That's the reason why there is an absence of a red glow currently. Now, I do a little bit of vitrectomy. The glow is now seen. There is a PC tear as well, but the challenge is to remove these thick, cheesy lens matter which is there and prevent it from dropping down posteriorly into the vitreous cavity. So the dispersive OVD which I've used is going to help me to plug that area of posterior defect and prevent the lens matter from falling down. And very patiently using a spatula and a dialer, this lens matter is maneuvered out from the capsular fornicis into the central pupillary area and then moved out into the antechamber, then out. Because this all has to be done once the vitrectomy has been done and the defect is covered by your dispersive OVD. So now we have a capsular bag which is free from all the lens matter. Of course, these are fibrotic small plaques which cannot be removed. I'm just trying to enlarge the capsular opening, and this is the posterior capsular tear which was pre-existing, which is visible now. The plan is to place a multi-piece lens into the sulcus and have an optic capture. I'm using this multi-piece lens. The haptics are dialed into the sulcus, and then the OVD which has been pushed behind the lens is then aspirated out using the cutter itself. Once it is done, once we are free of all the OVD which is behind and in front of the lens, the optic capture is achieved by just tapping the lens down under the rexus margin. And by that, we have a very clear optical axis, visual axis, and the lens is usually remains well centered for a long duration of time. So not an issue at all. So in these cases, the vitrector comes in extremely handy in membranous cataracts and absorbed cataracts. The challenge is really to deal with the anterior capsule and sometimes also with the posterior capsule. So this is how the eye looks at the end of the surgery. And at 1 month post-op, we have a very clear visual axis. And on dilated examination, we can also see that the lens is well centered. And we have this peripheral calcified anterior capsule, which is all right, which is not hindering the vision at all. Now moving on to the next case, again, a similar case, a long-standing traumatic cataract. And again, as soon as we stay in the anterior capsule, we can see these wrinkled anterior capsule. And these are the ones which are extremely tough to deal with. The cataract is not a challenge at all. Dealing with these anterior capsule itself is a challenge. Again, I'm using my vitrector to trim the anterior capsule. First, I make a nick, create a cleavage plane, and then introduce the cutter through it. And as soon as we start aspirating, we can clearly see that all the lens matter which is there, liquefied, just comes out in a jiffy. And we have a very small, tiny endonucleus in there. And again, the settings for the cutter which I'm using it's in IA cut mode, and the cutter is set at 2000. The cutting rate is set at 2000, and with very flow rate of 10 and vacuum of about 300. And very carefully and slowly, we can achieve a decent sized opening using this device. And I find this is an extremely safe device to use in such, to deal with such fibrotic capsules. And as I'm doing, you can see the small endonucleus floating around because he's a very young man. He's about 18 or 20 years old. And that nucleus would be taken care of in a jiffy. And without much of a stress, you can create a rexus of whatever dimensions which we can have. And just forward it here. And now I'm not made any incision. I'm just using 2 side ports to achieve this. To emulsify this nucleus, I'm going to make a corneal tunnel entry, and then using the phaco probe, just remove the small endonucleus, and the whatever little bit of lens matter which is remaining is aspirated out. The point which I would like to highlight here is that the cut margins with the vitrector which we see are relatively strong enough, and they withstand the maneuvers of which we usually have with your phacoemulsification. So I'm using this multi-piece lens into the bag, and while trying to manipulate it, you can see that the bag will withstand all the maneuvers and it doesn't run away radial. The cut edges are scalloped towards the center, and all these maneuvers it can easily withstand. So the margins are relatively strong enough, so that's not an issue at all. Even in cases with a slightly more denser or bigger cataract, the vitrector assisted capsulotomy will hold its ground. I think with these 2 cases, I would conclude my presentation. Again, I'm enlarging my the capsulotomy opening to the desired level, and it works out in a very controlled manner. So this is it. Thank you for watching.
Thank you, Dr. Deepak. It was the 2 cases were really mind blowing. Very nice. Any comment from any of the panelists?
Can I just ask one question, Deepak?
Yes.
You've done it through the vitrector and very nicely shown that it is so feasible and looks so elegant also. Alternatively, you could also have done it with a bimanual using a micro scissors and a micro forceps on one side, and then using a micro scissors and encompassing the area of fibrosis, going a little beyond it, because the fibrotic part may not cut even with the help of the micro scissors, but going beyond it, and maybe it would have still been scalloped, but doing it bimanually. So
Yes,
that also is an alternative in such cases where people are not very are not very dexterous with the vitrector. Can you again also repeat your settings for cutting this, because they are very different from it?
I think the cutting rate which I used in both the cases was on 2000 or 2500. Although I had an option of using 4000 as well with my machine, I cut down on the cutting rate because you have more of an opening when you slow down the cut rate. You get more of an time to engage the capsule. And because it's a peristaltic phaco machine which I was using, you have a flow rate, and flow rate is kept very less. It's kept at 10, and the vacuum is around 300 or 350. And I usually operate this in an IA cut mode. Usually for vitrectomy, you use the cut mode and then aspirate. Here, I'm using the aspirate mode and then cut mode. So aspirate, engage the capsule, and then it cuts.
Yeah. And then another question, Rajesh, which I'm sure everybody must be asking you, Deepak, and I'm asking you again. I have already asked you, which microscope and which camera is this?
Microscope
which is just
Lumera
unbeatable. the reflex, the recording is just superb.
Thank you, ma'am. Thank you. It's Lumera eye microscope, and I use a DSLR camera to record it, ma'am. Thank you, ma'am.
Yeah, actually, that's why I was looking for him. I was asking him for the last 2 weeks, because when you talk about videos, his name comes first. Yeah. And he has shown some wonderful videos earlier also in many of the conferences. Yeah, Amin.
Yeah. Fantastic video, sir. What is your experience with regards to capsular phimosis in such cases where there's already so much of fibrosis and you end up saving the bag and putting a lens inside the bag?
These are all fibrotic capsules. They are not like your fluid exfoliation, where there is a progressive weakening of the zonules, and that's the reason the capsule size comes down. These are fibrotic. It's an event which is I have not seen them decrease in size. The opening which you create, they don't decrease in size over a period of time, and this is related to trauma. and they don't have any pre-existing zonulopathy, which is going to exacerbate these things, at least in these cases which I've seen shown here. So I'm not so much concerned of the phimosis part in these situations, even when I cut with the vitrector.
Yeah, I completely agree with, because once it's completely fibrosed, no, and you cut that, then there's no element which is further going to fibrose. There's nothing there which is further going to fibrose. So there won't be further fibrosis. So the risk of phimosis is less. I have one question for you. Why you had implanted multi-piece lens in the bag in the second case?
Actually, I was not sure when you begin the surgery, you'll not be sure whether the lens is going to be in the bag or in the sulcus, because only once you enter, you will come to know what is the situation. So I had planned a multi-piece lens by the way. If the posterior capsule is not intact, then I'm going to use the same lens to place it in the sulcus. So that's the reason we had gone pre-planned with the multi-piece lens.
Okay, okay. And the defect in the first case wherein there was a PC defect, you very well, managed to get all the pieces out without getting it dropped in the vitreous cavity. So that was really, that was, I completely agreed that was a real challenge in that, to get everything out without letting any cortical fiber falling behind. And particularly when you have such a fibrotic, calcific kind of a cortical matter, the risk is very high that it can sometimes, while removing it, aspirating it, it can fall back.
Yeah. I think one is a dispersive OVD. You have to put it at the right time and plug it. And second, obviously, you need to be lucky also. I can't deny that fact.
So another wonderful, set of cases that we will have from Dr. Love Kochigave, who will be talking about pre-existing PC defects. So let's see his videos and we can discuss together.
Is my screen visible?
Your screen is visible. Yes, yes, it is visible. Yeah.
So I would be presenting a series of cases, both pediatric and adult, in which we see a pre-existing PC defect. And the first one, which is the most common in pediatric cataract setting, and especially if you see unilateral cataract, non-traumatic in children, we should always suspect a posterior lenticonus. So the most important part is avoid hydrodissection in these cases, because once vitreous prolapses, then it becomes a very messy affair. So what you could see here was that without hydrodissection, I started with the cortical aspiration straight away after the rexis, and very carefully we have to be careful that the small pieces don't fall off behind. And what you see at the end is a typical wedge-shaped large PC defect after the cortical aspiration. So posterior capsular rexis obviously is not required in these cases. What we did was dry vitrectomy and then tried to place the lens in the bag. Three-piece lens, again, over the years, I've become much more comfortable with three-piece lenses, and that has an advantage that if you're not able to place it in the bag, it can always be placed in the sulcus with the optic capture. But we were lucky in this case, and at the end of it, very gentle washing of the viscoelastic material. Next is a similar case, a child with a blunt trauma, and what you can see is a very sharp edge of the posterior capsule through the almost a total cataract. So we are aware, and this may not be visible in the OPD because generally children don't cooperate for slit lamp examination. So be very careful, and if once this is available, then seen, then we are aware that it is a pre-existing defect. And what you see here is a mistake. I just decompressed it without pushing in viscoelastic. So once you do that, there are chances that vitreous will be there in the anterior chamber, and this is how we identified it, because the lens was not going into the sulcus. So that means you have vitreous in the AC, so stop it there. I think I prolonged this manipulation a bit too long, which should not have been done. And then tackle the vitreous first. And once vitrectomy is done, after that, when you dial the lens, it will very smoothly go into the sulcus. And this is how it goes. So this was a learning thing for all of us, which we have to learn from our mistakes, did a optic capture also. And at the end of it, the lens is quite well centered. These are the two situations, especially in pediatric cataract, when we experience pre-existing defect. In adult cataract, similar situation is in a posterior polar cataract. And what I generally try is that I try to do a slightly larger axis so that manipulation is less, and only hydrodelineation. As you can see, after the hydrodelineation, the lens nucleus has come into the anterior chamber, and then it is aspirated. And most important here is to avoid decompression. So whenever you are removing your handpiece, the AC is the viscoelastic is pushed in, and then the handpiece is removed. And the cortex is a bit sticky, but as gentle aspiration, we could manage without PC rent. And once this is complete, again push in viscoelastic, and before taking out the irrigation cannula. And the lens is placed, and since and while implanting the lens, what you see here is that it has given way. So, but there was no vitreous loss, so we placed the lens in the sulcus with a optic capture. Third is a slightly harder cataract and a posterior polar cataract. So again, normally I do 5 to 5.5 millimeter axis. In this case, around 6 millimeter. And as you can see, the pupil is also becoming smaller in the initial stages itself. Hydrodissection was not done, just a spatula is used to separate the cortical fibers from the anterior axis margin. And gently small pieces are chopped. And since we had avoided hydrodissection, we have a cushion of the cortical fibers. AC decompression is again avoided, and cortex is being removed, but the pupil is giving way in between. So safest is to not to struggle blindly. The capsular hooks, the iris hooks were used, and now the visibility has improved. And while doing, you identify the PC rent and the end stages of it. So even with all precautions, the posterior polar, the PC can give way, which is evident from this, and the lens is placed in the sulcus. Unfortunately, again, there was no vitreous loss, so vitrectomy need not be used. Once you see a round pupil at the end of the surgery after pilocarpine was used. And this is the end of it. Thank you.
Thank you, Dr. Love. Thanks for showing wonderful cases. Any comment on these wonderful way of managing these pre-existing? Yeah, Dr. Rajesh, please.
Doctor, it was an excellent surgery. Just a small query. In the third case, it was how could you make out it was a posterior polar because it was a slightly dense cataract? Is there any way we can?
The fourth one. In slit lamp, it was available. In slit lamp, it was quite clear. And
fine, doctor. And that was the thing. Thank you, doctor. Thanks a lot, doctor.
I think, yeah, please. Yeah.
Love, can you hear me? Sorry, Love.
Yes,
In
yes,
your
yes.
last case, that posterior polar, you said you had dissected with a spatula, isn't it?
Yeah, dry.
Delineation, was it done or not?
No, it was
Delineation
not done.
not done. Okay.
Because it
I
was a
didn't-
dense cataract.
Yeah,
and
yeah.
you will not get that.
I think if it's a very important point that was mentioned, and that is really key when you are handling a case of a pre-existing posterior capsular defect, is that, or whenever there is a PC defect, that the chamber should not collapse at any point of time, because then you can have a very badly extended capsular defect, and that can create a lot of problems. So
That mistake was done in my second case.
yeah. So Dr. Deepak, any comment on this?
No, I think all was wonderfully performed surgeries. Congratulations. I think few pediatric cataracts wherein you posterior lenticonus, you need to have a strong suspicion, because in unilateral cases, but he showed most of the cases very well managed. Congratulations, sir.
Thank you.
Okay, thank you, Dr. Love. It was really, all the cases were really challenging.
Can you hear me?
Yeah, yes, sir. Please, Dr. Bharti. Go ahead.
I am Dr. Bharti from Faridabad. I just want to ask one question, that if you feel there is a posterior capsule tear and small pieces can fall off, how to prevent it? How you prevent small pieces not going into the vitreous?
Sudden decompression has to be avoided. First is sudden decompression has to be avoided. And when, especially in pediatric cataracts, generally they don't fall because you have not done hydrodissection. Hydrodissection has not been done, so they are sticky with the capsule only. And in small pieces, if you can keep removing, and suppose if you have slightly doubt, then push a little viscoelastic and then restart it again.
So viscoelastic should be put behind the pieces.
Yeah, in the bag only, in the bag.
Right. Thank you.
Yeah, Dr. Rajesh, please.
So is there any way where we can find out pre-existing PC rent like OCT or some which will be, so that we can plan our surgery accordingly?
Problem is children don't cooperate with these machines. And
even in adults, like even like as a general
segment OCT, it can be documented.
Thank you, sir. Thank you, sir.
Pre-existing defects can be, we can have an idea of pre-existing defects, if it's a total cataract, you can do a UBM, and that will also give you an idea about this thing. Then with the help of KCA also, you can get an idea what is the status of the posterior capsular defect. But apart from all these, by simple examination, and sometimes you don't get to see and you get a surprise on the table, so you have to handle all that. So that's what Dr. Love was mentioning, that at times you do get surprises as well on the table. So we move on to the next talk, and we have Dr. R.C. Paul, who is the chairman of Sushrita Eye Hospital at Kolkata. He'll be presenting to us another challenging scenario, and that is uveitic cataract. Sir, all yours.
Thank you, Dr. Rajesh, and my colleagues for giving me the opportunity to share in this platform. Can I share?
Yes, sir. Please.
So, in uveitic cataract, if we just analyze the major factors, maybe one is the the pupil size. Can you share it? Thank you. Pupil size, small pupil. Others are definitely the friable tissues. The friable tissues means iris can be friable, jonules friables, capsule friables. And of course, because of the repeated inflammation, the anterior chamber is shallow. So that's why there is a surgical challenge. So for the pupillary dilatation, really we can use, one is pharmacological dilatation, then is dispersive OBDs, and today I'll be sharing one. This is retropapillary membrane peeling in CCC manner. So let me share one small video clips. This is a typical uveitic cataract. So you can notice by taking an forceps simply a membrane which is attached between the back of the iris in the pupillary margin and the anterior lens capsule is separated, and in complex case is being converted into an easy cataract. This is a post-op photograph. Now if I just elaborate little bit with a snapshot, so this is the membrane which has to be grasped and had to be taken more time with repeated attempt. One thing also has to be kept in mind, while I am pulling the things, it may give rise to an injury at the root of the iris. So I have to be very careful that the force is not that strong. This is one of the parts. Sometimes we find the membrane is really tough one. Sometimes we find the membrane, the force is sometimes irregular. So, but what happens in the postoperative phase, as this membranes develops following the repeated attack of the uveitis, it decreases the load as because this membrane is being separated. And on the other hand, this complex cataract is being turned into a very routine cataract. So in the discussion part, there are area of techniques, but this is the most efficient in terms of outcome. What I said because of the outcome is really in the postoperative phase, you don't need to change the post-op regime, especially the steroid, either be it systemic or topical. So as we use maybe for 3 to 4 weeks, the steroid 4 times, 3 times, 2 times, 1 time is sufficient. And the hardly in a series of last 4 years, I have found any incidence of refractory recurrent uveitis in the post-pseudophakic one. And for the outcome, one is again important issue in the postoperative phase to really have an look into any presence of cyclitic membrane. If the cyclitic membrane is there, so this is through the pars plana vitrectomy with the help of the retinal colleague. Probably this cyclitic membrane had to be removed because that has a long-term effect on good quality of cataract surgery with the uveitic cataract, which can land up into termination of vision or the poor outcome. Unfortunately, there are only few studies done on the membrane peeling. One of them published in the IGO. I have mentioned it. So take-home message is the uveitic cataract need not to be panic. Some people we have seen in case of even refractory uveitis, it is not responding even to immunosuppressions. So some of the case I did with with mild degree of uveitis, though it is a deviation from the normal routine practice that I should be quiet for 3 months. But fortunately, I have not found any refractory uveitis in the postoperative phase. So one word, safe peeling, safe surgery, and definitely will be added with HP and the immunoassay of the membrane studies, exactly what this membrane in the retropapillary area that contains. So I have given for the studies, and this is going on. So these are some of the references. With these few words, I thank you again, all my colleagues, for your patience. Thank you.
Thank you, sir. Thanks for wonderful pearls and wonderful tips that you gave. Any comment from any of the panelists?
Yes, sir.
Yeah, Dr. Bharti, please.
Yeah, I have seen in such like cases, every time there is post-operative uveitis, and you need to give atropine and other things and steroids orally also to take it off, and again membrane formation is there?
Sir, my experience is totally different. My experience for the last 4 years is totally different. Yet I have to identify in single case where I have to, number one, I told you I don't need to enhance the topical steroid even. This is a routine steroid, the regime we follow. This is 4-type prednisolone definitely is being used in routine cataract in our center. 4 times for 7 days, 3 times for 7 days, and 2 times for 7 days, and 1 times for 7 days. So this is not being changed. Even I mentioned you in some of the refractory uveitis which are not responding to steroid, even with the immunosuppressant, where some flares are there, maybe very minute cells is there. This is not quite for even 3 months. So I did the case, but I don't know my experience. I didn't get, sir, honestly speaking, any refractory uveitis.
Okay.
Yeah, Ilan, please.
Sir, that's a good, excellent surgery. Just one question. Do you look at any systemic points or any lab investigations along with this? Because you said almost no post-op uveitis. Is there any correlation? Because what I've noticed, particularly in those where the systemic status is not controlled, where the ESR is high, definitely there is a recurrence of uveitis in the post-operative period with our normal regimen.
It is, of course, it is a very valid question. If there is a systemic point, particularly in case of the uveitis, this is a major group, and it's not wise to discuss all these things over here. But rightly, you have mentioned that if the systemic factors are not being controlled well, this is one of the factors why the recurrence is there. Thank you for bringing this point in.
Okay, so we are talking about post-operative regime and in uveitic cataract. So if there's a case of a uveitic cataract with Sine K and all that, and you have to do a cataract surgery, so what post-operative regime you follow, and how do we start? Like many times we do start steroid, topical as well as systemic, from the preoperative period. So any comment from any of the panelists? So would like to comment on? Yeah,
I
please.
can just one comment on. I think it was an excellent technique and an excellent point, because I think people do miss this point, which Dr. Paul sir has rightfully brought out, that there is a membrane which is present all along, and this is, I think, called as the osseous membrane, and if you remove it, you'll be surprised, pleasantly surprised to see that how the pupil dilates, which was so elegantly shown in his surgery and remained so throughout the surgery. It did not come back to its original meiosis. Regarding the regime, I think topical steroids have to be started beforehand only, and also the NSAID, because even when you remove this membrane, the pupil should remain dilated, and I think that helps if you do start something like a Nipafenec beforehand or a NSAID beforehand, and then topical steroids, like Dr. Paul sir also said, have to be continued post-operatively and then tapered subsequently. But I think there is no role of I mean, unless systemic investigations say so, there is no role of investigations, systemic immunosuppression in those cases.
Yeah. Dr. Paul sir, I wanted to know from you, do you routinely prescribe these cycloplegic drops, say like in a post-op period in any routine cataract?
No, sir. No, actually, in the routine, we don't use any either tropicamide or homatropine or atropine. I know RP center there is a practice probably using atropine.
Sir, do you do that in uveitic cataracts, sir?
No, sir.
Actually, not even in uveitic.
Not even, because that is what is surprising. What I told, if we really membrane, the peeling is 100% and can be done in a very efficient manner. So we are waiting for the result. Actually, what is the constituents of this membrane is. This is an apprehension. Probably removing this membrane is somehow or other decreasing the load of the post-op reaction. Probably we know this is in the cataract surgery means damaging the blood aqueous barrier. and there will be a transient phase. And in case of the uveitic cataract, the chances are more. But once we decrease this load by removing efficiently this membrane part is 100%, probably this is one of the part which is enhancing the result.
Sir. And these days, there are steroid implants available in the market. So have you used in uveitic cataract these Ozurdex implants or any other implants?
I never used. I never used. I don't have any experience.
Sir. Yeah, Dr. Rajesh. Yeah.
Yeah, Dr. Paul said it was an excellent learning curve for all of us, sir. And the retropupillary membrane, I think, just a few of the things. Is the retropupillary membrane, is it attached to the pupillary margin also, and how does the pupil react in the post-op period? Second thing is, what type of IOL material do you prefer? And the final thing is, how long do you continue NSAID post-op? So this.
So I'm starting from the last. NSAID is routinely given for 6 weeks time, 3 days, 3 times in a day for 6 days. Another point is very interesting, which I have brought forward, is where exactly anatomically this membrane is to be for dissections or for the removing. Interestingly, this is from the pupillary margin goes behind the iris. This is very important. Once we remove, this goes behind the iris. It starts at the pupillary margin and it goes behind the iris. This is number 1 point. Number 2 point, the distal end of it remains attached to the anterior capsule.
Fine, sir. Fine, sir. How does the pupil react, sir, post-op period, sir? Sorry.
Sir, I showed you. I have plenty of videos, 10, 15, which I kept in our library. That really turns into an well-dilated, pupil on the table for the surgery.
Yes, congratulations.
And my experience, I never used, even don't need to. It is very difficult to distinguish the look of the preoperative cataract and the preoperative eye. It is sometimes becomes very difficult that it was an uveitic cataract in the post-op and differentiate it between a normal routine cataract from the this uveitic cataract. Believe me, sir, practice it. It's really interesting.
Thank you very much.
It is very much possible with the huge experience that you have. And that's how, that's why, patients want to get operated from surgeons like you who have loads of experience in handling such cases. Thanks a lot, sir. Thank you. And we now move on to our next speaker, and that is Dr. Amey Kulkarni, who will be showing us a unique, not unique, but a standard method of what one should do what method should be employed for cortical aspiration. And he has named it the hurricane technique of cortical aspiration.
Yes, sir. That's right.
Yeah.
I'm not able to just. At the outset, I would like to have a disclaimer that I have not named the technique.
The hurricane cortical aspiration.
Neither have I invented it. This was basically done by Dr. Celso Takashi Nakato et al. In Japan, and it was first published in the Journal of Cataract and Refractive Surgery in 2014. I just got hold of a very rare video that they have of that particular technique, and Dr. Rajesh loves that video, and he's been behind me to show that video to everybody. So here it is. It's a very self-explanatory video. It's a small video. I'll show it to you, and if I'm able to share the screen properly, just bear with me.
Cortical aspiration. This first video shows a frontal view of an eye. The iris was removed and retroillumination was used to highlight the zonal and capsular bag complex. Radio aspiration is being performed to a small portion of the cortex. The same movement is presented now from a posterior view. Notice the traction against the zonals and the capsular bag deformation. In this next video, with a higher magnification, we could observe again the traction against the zonals and the capsular bag, mostly during the early movements of the detachment of the cortical material from the capsular bag. Now, we are going to view a tangential cortical aspiration in this posterior view. Notice the smooth detachment of the cortex with almost no deformation of the capsular bag. This image shows the continuation of the tangential movement in real time. Again, in slow motion, see the continuous aspiration of the cortical material one after another, with almost no traction to the zonals and capsular bag. This image illustrates both approaches to aspirate cortical material. Look at the zonals and the bubbles movements. Look how gentle is the releasing of the cortex during tangential mode. These last videos show the continuous circular one-step cortical aspiration, frontal view and back view.
So that was the video that showed us the one-step continuous circular cortical aspiration, also termed the hurricane aspiration technique by Dr. Nakano and et al. And it basically reduces the stress on the zonules by better distribution of the tractional forces while we are doing the aspiration. That's the takeaway. And every time today, even today, when I do cortical aspiration, this video is in the back of my mind. No matter how hurriedly you're doing a surgery, they always pull the material tangentially and not towards the center, as has been the conventional technique. Thank you.
Thank you, Dr. Ame. And it really, the first time when I had seen it, it really, looked very interesting, and even it looks interesting now. So that's why I thought that it should be presented again. Any comment from any of the panelists? Yeah, Dr. Rajesh, please.
Dr. Ame, it was really excellent. It just reminds me of can it be also termed as cortical capsular axis, like anti-capsule, we move it in one direction. Similar way, we are just, the video what we saw was you are going tangentially and moving without any strain on the zonules. It is just similar to the capsular axis type.
Yes,
it was an excellent presentation, sir. Thank you. Congrats, sir.
Actually, whenever there is a zonal deficiency, it is always suggested that you should not pull it radially. You should always pull it tangentially. But I mean, in any case, if you can have a tangential pull, then in that case, the stress on zonules will be less.
Even when we put a CTR, we've seen that people delay putting the CTR, saying they can't take the cortex out because they're pulling the cortex radially and the CTR tends to slip out. So this is how you can avoid, put the CTI early, save the bag, and still take the cortex out.
I think it was really very convincing, because the way you showed it, it was absolutely convincing. Maybe, you know, it doesn't sink in when you are doing your cases, but you showed through the Miyake view, and it was absolutely convincing. And I'm glad that you brought it out, and that Rajesh asked you to, you know, to show this again, because I'm sure many of us have not actually seen it. And although theoretically we might believe, like Dr. Rajesh also pointed out, that in those wherever you have a zonular deficiency, you should go tangentially, but then, you know, this clears it all.
Yeah. Anything, Ellen?
Also, it just has come to my mind. Do you think that the port which is there, which is just like a point, should also be made a little elongated, ovalish rather than a circle, so that, you know, that oval part of it grasps the cortical material rather than, I think, Amey, you should work on something like this and maybe patent it on your name.
Just two things to add, sir. One, once we do this, it becomes faster also. I mean, safer, definitely, but faster also once we do this.
Yes, sir.
Yeah, Dr. Tejesh.
Dr. Kulkarni, I was just in the car, got stuck up in the traffic, but I was watching all the videos, wonderful videos and good surgeries by everybody. Dr. Kulkarni, I just have a question, not a question, but my experience is that I have been doing this tangential aspiration also, but it becomes a real difficult case if you do not have a complete rhexis, if not a proper rhexis, and if a free tag of the anterior capsule gets attached to the probe, then the problem really arises. So that is a point to be taken care of, that you do not have this thing. Otherwise, the tangential pull will just pull out the whole thing. Yeah,
Sir, basically, I believe it's basically the other way around. If you do have a tag, it is better to pull tangentially, because you can make out that it's being pulled rather than you pulling it radially and it just, the zonules give way and the entire back collapses.
Yeah, a radial pull would be, but a tangential pull also has to be, you have to be careful about it. That's what I mean. Yeah.
Yes.
Yes.
Any comment, Rajiv?
No, I think amazing presentation, and those views really make us help us understand the stress on the zonules, how it is, how it works. So I think this is something we need to follow and try out in our day-to-day practice. I must congratulate Amey. Fantastic.
Thank you, sir. Thank
you. I would just like to ask you all one thing, all the panelists and the speakers, that, you know, we have been doing posterior capsular rhexis in pediatric cataracts. In a child wherein there is a uveitic cataract, would you like to do a posterior capsular rhexis in that case?
Yes, sir, because again, the PCO will be much more in those cases. But problem is that in children in uveitic cataract, post-op reaction is very much, is quite, especially if you have implanted a IOL.
Yeah. So it is actually two-way, double-edged sword, because if you do a posterior capsular rhexis, the chance of PCO is high. But if you do a posterior capsular rhexis, the risk of cystoid macular edema will be very high.
Yes. It's one of the most difficult situation, I would say, in cataract surgery.
Yeah. And Dr. Love, have you tried these Orthodex implants, etc., in these cases in uveitic?
No, it's a good idea. I think we can try. It didn't come into my mind till now. Since you have told, yeah, it's a good idea.
Okay. Madam, would you like to say something? Actually, unfortunately, Dr. Sonu Goyal is not present here because his friend, one of his closest friend has expired and he has to go there. And his laptop has crashed. So,
Sir, Dr. Rajesh, sir, can I just add regarding this Ozurdex?
Yeah,
I've used it in one case. Now, this was a lady where she had an advanced cataract, and finally, when it was getting postponed because of recurrent uveitis. So, in this case, I didn't wait for the usual 6 months period. Went ahead after, inactivity of around 3 months. We had 4 episodes in the last 2 years, and we had to postpone this cataract. So finally, when I did it, put an Ozurdex. Now it is 6 months, bilateral actually. 6 months now, and luckily she has not had any recurrences. Though vision is definitely better than that what she had before, but it is only I think 6-12 parts both eyes. Ozurdex is definitely helping in preventing recurrences at least. Otherwise, this would have been only one Ozurdex.
What about the intraocular pressure? Do you?
No, ma'am. I've been watching this patient almost every 15 days. Nothing has happened to the intraocular pressure. Luckily, so far. This has been told to her and taken a consent also. And only one implant that usually stays for 2 to 3 months, I think. But 6 months down the line, till now we have not had a recurrence.
So, Dr. Rajesh, I know that you have done Ozurdex implants in cataract cases. Any raised intraocular pressure in any of those cases, or you think it benefits?
Yeah, fortunately, I haven't noted any raised intraocular pressure, but the number of cases that I would like to do to actually make a statement should be higher than what I have done, because I had started doing it before this COVID pandemic. And then after that, after that I have not used till date. So before that, I have done that, and in those cases wherein I have used, I did not encounter any high intraocular pressure. It is helpful in terms of reducing the requirement of topical steroid. It does help in reducing the inflammation. But then, having said that, we cannot make a definite statement unless we do a randomized study putting Ozurdex implant in one group and not putting in another group with a similar kind of a post-op regime. And then only we will be in a position to actually tell. So that's why since I've done it a little bit, I would say, but I've not done a study. So that's why I wanted to have the opinion of other panelists that whether they have used it and whether they have any experience of this implant. So any other comment? Dr. Deepak, actually Dr. Deepak is there to present another video, and
so anyone would have any experience? We were talking about capsular phimosis, on how people have dealt with capsular phimosis. Rajiv, would you have any experience?
I think one of the most appropriate persons to answer that question should be Dr. Bharti Gupta from Faridabad. He's a very, very high volume cataract surgeon, and he's seen all that we probably don't see in a lifetime. Sir, would you like to comment, Dr. Gupta?
Yeah, there are many cases with capsular phimosis, and very difficult to operate such like cases. But the difficulty, I think, with a lot of methyl cellulose to dilate the capsule, we can do it.
So, sir, you normally prefer to cut with the help of the scissors, or just like Dr. Deepak Meghur showed with the
scissors only.
With the scissors.
And which scissor you use? Is it a micro scissor? Or?
Yeah, Bana scissors.
Okay.
Very small scissors.
Okay.
Madam, I would say what I have experienced is in pediatric cataracts post lensectomy, quite frequent. Very young children, if you have done and left an anterior capsular rim, and many times it just contracts and comes back to the visual axis gets opacified. So you have to take them again to the OT, then do a membranectomy. Adults, few, and that we cut with YAG. That is, I'm telling for post-op, for post-surgery capsular phimosis.
Okay, so we have Dr. Deepak Migur, and he'll be doing another presentation, another video, very interesting video that he has. And let's have his video, and then we can discuss further.
Let me see whether this video has an audio also. Okay, I'll be speaking. He is a 70-year-old gentleman who has sustained blunt trauma, and he has got zonular dehiscence, and it's about 3 to 4 clock hours here. And the cataract is intermittent, as we can see here. And the challenges to this are, first we have to get the rhexis right in this situation, because rhexis probably is the most important thing, because it's sort is we are going to stabilize the bag. As soon as I stain the capsule, and I'm worried that there's something fishy in this area. So I was suspecting that maybe there is already a vitreous prolapse. So I'm just trying to confirm it by staining with the triamcinolone acetate, and you can see this tongue-shaped protrusion of the vitreous, which is transzonular. And so I need to deal with the vitreous first before even considering capsulorhexis. So I'm using the 23G cutter to do a vitrectomy here. And once the prolapsed vitreous is taken care of, then would be the next steps would be there. So once the vitreous is taken care of, I would want to tamponate this area by using dispersive OVD, that is viscoat or viscoat-like substance, to prevent further prolapse of the vitreous. So once the area is tamponate, underneath the viscoat, I'm putting sodium hyaluronate as a soft shell technique. Now I need to get my rhexis right, and it needs to be centered also well enough, because I need to center it on the lens, not on the bag, not on the iris or the pupil. Because it's an intermittent cataract, I'm a little bit careful and to ensure that I get the rhexis right. I don't have a rhexis extension. I'm using a capsule hook to stabilize this area here. And I want to put the CTR in first itself. So I'm deepening the bag by using sodium hyaluronate, and then the capsule tension ring is threaded to support that area. Because it's a localized zonular defect, I thought that I can get away only with the CTR itself. The dehiscence area is around 3 to 4 clock hours. The nucleus is relatively soft because it's a white cataract and it's soft. So the nucleus division is not going to be much of a challenge here. And the vertical chop and lateral separation maneuvers are being done. And once the nucleus is divided into smaller fragments, then carefully need to emulsify all of these the fragments. Another important aspect to note or be concerned about is the chance of fluid misdirection syndrome, because the fluid from the phaco sleeves has every chance to traverse across the zonular defect and go behind. That will push the entire bag anteriorly. And at this moment, there is again a slight prolapse of this vitreous. Again, it need to be taken care of before venturing into other steps. The white thing which you're seeing is actually the vitreous which is stained, and it is behind the posterior capsule. Again, once the vitreous prolapse is taken care of, I'm just tamponating that area with the dispersive OVD. And to take care of this prolapsed transzonular prolapsed vitreous, I am now decided to go through the pars plana route to take care of this area of vitreous which is repeatedly prolapsing. Care has to be taken that we don't damage the posterior capsule now, and a limited amount of anti-vitrectomy, that's all is required. And once it is done, then would be my time to put the intraocular lens. I'm suturing that pars plana incision with an 8-0 fluid suture. In this case, I've decided to use the IOL trap technique, wherein I am placing the multi-piece intraocular lens with the haptics in the bag, in the sulcus, and I'm going to capture the optic within the rhexis margin. So that is done only after aspirating all the OVD, which is behind the lens in the bag. Once the OVD is aspirated out, I'm just going to push back the optic inside to achieve this optic capture. Just trying to rule out any prolapsed vitreous and trying to do this. And this is how the end position looks like. You have the intraocular lens is locked into the rexus, and these are the first day post-op pictures. And eventually the patient did well. And this ensures a long-term centration. So that was it. Thank you for attention.
Fantastic, Deepak. Could you just elaborate for the help of others? When would you use IA cut and when would you use I cut and then A? When you're doing vitrectomy?
Yeah, I think that's an excellent point, sir. And the first thing would be, most often than not, to begin with, whenever there's a prolapse vitreous, always I would start with the cut first and then aspirate. But there are situations where we would want to remove the cortex or try to trim the posterior capsule or the anterior capsule. That's the area when I would use the IA cut method. You've done a vitrectomy and then you would want to deal with the cortex which is there. And that is, you can use the same instrument, the vitrector itself. I would switch then to IA cut mode, then aspirate the cortex into the centrifugal zone and then try to aspirate it. It doesn't, then use a short burst of cut. A second reason when I'm using IA cut is there'll be one single vitreous strand which is prolapsing, and maybe that is causing the pupil to tweak a little bit. And that is, these single strands are extremely difficult to cut using the cut aspiration mode. And these are the situation when I'm trying to deal with a single vitreous strand. That is again a situation where I would use the IA cut mode.
Fantastic, Deepak. And what would be your modulation of IOL power, considering that you are doing a capture or a sulcus fixation?
Yeah, in this case, whenever there is an optic capture, sir, I won't change the IOL power simply because the optic place is going back into the bag itself. Because only the haptics are in the sulcus, the optic is pushed back behind the anterior capsule. So in these situations, there is no change in the IOL power. In situations where I'm not able to achieve optic capture, then I will undercorrect by 0.5 diopters.
Fantastic. And great videos as always, Deepak.
Thank you, sir.
So glad to see them each time.
Thank you, sir.
Thank you. And we will have the last video from Dr. Namrata Sharma, who will be showing us a video on cataract surgery, phacoemulsification in eyes with corneal graft. So, madam, are you ready?
Yes, I'll have
please.
to, skip a few things because this was not intended for today's presentation, but I will just show you some cases where we had done keratoplasty, where we had done phacoemulsification after keratoplasty, and I think I'll just stick to that. I think after keratoplasty, it is always very tricky to choose the intraocular lens. And most of the times we try to go in for a monofocal lens because the keratometry may be haywire, and ultrasonic B scan always has to be done. And sometimes you may not be able to get the power of the intraocular lens through the IOL master. And this is how these cases may look like. This is a case of post-DALC macular dystrophy and then a cataract after that. Now, this is just to show a case of post-DALC phacoemulsification. Again, in these cases, this was a time when we didn't have the imaging system, so we were still manually marking, and a toric intraocular lens had been planned in this case. Important thing is that all the sutures should be out unless the case is intumescent or white cataract and the graft has been recent. In those cases, it may not be possible to take out the sutures. Then, of course, we begin with the rexis, which is done with the help of the capsulorhexis forceps and hydro procedures, which again have to be done. This is followed by the phacoemulsification, which we would do normally as we do our conventional cases, and followed by irrigation and aspiration, and subsequently intraocular lens implantation. Now, ever since Amia has told me, Dr. Amia has told me when I'm trying to watch what sort of a aspiration I'm doing, whether tangential or radial, it seems I've done a radial aspiration here, and then viscoelastic is instilled, followed by a toric intraocular lens which have been implanted. Now, toric intraocular lenses, in these cases, you can only implant provided you don't have too much of irregular astigmatism, and the astigmatism is only regular, and then that has been confirmed on topography. So suffice it to say that the topography is very essential in these cases, and of course, the lenses have to be placed in a position after in a particular axis after confirming the same with the help of the marker. Now, sometimes, like I said earlier, also you have cases like this where we are still doing phacoemulsification when the sutures are in situ, mainly for the reason that this is a case which is absolutely white and intumescent, and it's a post PK cataract, and the keratoplasty is about only 6 months old, so you can't afford to remove the sutures. And as you go underneath that area of pterygium, and this case was operated elsewhere, it is important that you just go in one go. And then this is followed by the aspiration of the lens matter, and it is fluffy. It comes out very easily, followed by a foldable intraocular lens. And then this pterygium is also being taken care of, because while the patient is there, it is important that this also is sorted out in the same sitting with the help of a autoconch graft. Now, of course, this is again a case just to show that when you have again a referred case with penetrating keratoplasty with the continuous suture with a white cataract, again the part of the cornea which is hazy, and then this was a case where PK was done for limbal stem cell deficiency, so the pannus has come out. Pannus has come back again. So the pannus should be removed, and when you remove the pannus, then it becomes almost as clear as any case would be. And these cases can be tricky, and like I said, always avoid the suture should not be in place unless when you can't remove the suture, in this case keratoplasty which was just about 4 months old. So sometimes the cases can be very complex, like perforation and a patch graft, and then a white cataract which is showing from here in a one-eyed patient, and then you do a phacoemulsification, and then the post-op visual acuity is good with some amount of glow which is there. At least the patient is ambulatory. I think this can be skipped because this is not post-keratoplasty, but these are simultaneous procedures. This is one case where tuck-in lamellar keratoplasty was done for pellucid marginal degeneration. And again, the cataract is white. There are 2 sutures which are still, we try to remove them, but could only remove partially. So in this case, the surgery is being undertaken, and then again, the rhexis is fashioned, and it's a white cataract, but the milky fluid is not coming out, and relatively young patient. So this is a case which is easy to do, followed by cortical aspiration, and then by foldable intraocular lens implantation. And then this is just to show that, notice how this this part which is there posteriorly is moving, and this can only be appreciated on a intraoppository microscope. So air bubble is being instilled so that there is no gap present between this area of the graft and the recipient bed, and still there's some amount of fluid present. So the stab incisions are being given anteriorly, and then air bubble is instilled again so that there is no gap between the recipient and the donor. So these kind of things you can appreciate on the intraop OCT microscope. So this also I would skip because this does not relate to post-keratoplastic cataract. And this is a case where penetrating keratoplasty had been done, and then a DSEC was done, and then there was a cataract. So it is a post-PK DSEC cataract. And like Dr. Paul had described, that there is a membrane there. So there is a membrane even in this case. When you stain it with the trypan blue dye and you try to remove that this part of it is not a rhexis part, but there is some amount of the membranous part which is being removed. And when you stain it, sometimes it even stains with the trypan blue dye. And then again, a nick is given in the capsule, and the capsulorhexis is fashioned. And as you do, because this is a DSEC also here, so as you do phacoemulsification, notice everything is looking fine here and the graft is quite stuck. But, and this is irrigation aspiration followed by foldable intraocular lens implantation. But as you give as you do hydration, this graft moves a little bit. And like I say always, if you don't have the IOCT, you will probably not detect it. But when you try to hydrate the wound, and even in the beginning, possibly has occurred during IOL implantation. So when you know that this gap is there, then you can always aspirate and then put an air bubble in the end to see that the DSEC graft, doesn't come out and it is quite stuck. And this helps you to inspect the same. So, and sometimes even post keratoplasty, this was a post DAL case which had a Descemet's membrane detachment, and this is being addressed. So as you put the air bubble, there is still some amount of detachment which is there. It's not come out by air bubble also, so you have to give stab incisions anteriorly. And these problems can occur in graft cases which have been grafted. And when you give the stab incisions, you put the air bubble again there, and then your graft is now quite stuck. And so thank you very much. And I think that was all about the post keratoplasty cataracts.
Thank you, ma'am, for some excellent videos. Very nice. Any comment or question from any of the panelists?
That was indeed a fantastic display of surgical skills from Dr. Namrata. I also do these cataracts, but I know the degree of difficulties. Two things that come to mind whenever I take up a case like this. Number one is the biometry. That's indeed a nightmare in post-keratoplasty eyes, especially ones with sutures on irregular corneas. Doing a toric IOL is another thing I would or would not comes into mind, because if that graft rejects and I have to change the graft, the entire scenario of the refractive status of the eye cannot be matched again. See, if I had put in a toric IOL earlier. Third thing that I always consider doing cataract surgeries in eyes with grafts, especially in eyes where lamellar grafts are done, is that fluid misdirection. Can or might have a theoretical possibility of detaching or causing a separation between your two layers of the cornea. So these are apart from the challenges of cataract surgery itself. So these are few things that I always struggle with in my mind when I have to go in for a case like this. How would you solve them?
So like you said, and I think some of it was shown and some of it was not shown. Like you said, Rajiv, it is always a tricky situation to plan a toric IOL or to do a monofocal in these cases. Like I said, if it is only a regular astigmatism, then you can possibly plan a toric intraocular lens. But if there is an irregular astigmatism component, then probably that is not a great idea to do so. But then astigmatic part is something which, you will have to take care of either through the hard contact lenses or through other methods of treating it. And if that component is there, then that is addressed better before rather than after the cataract surgery. So one is this. Two is, yes, there's always a fear that your DSEC grafts or your DAL grafts there might be a gap and there might be an interface because of the fluid misdirection. And I think at the end of the procedure, one has to be very careful to see that the cataract is taken care of, and now your grafts are also, attached and are well in position and morphologically and anatomically looking okay, because they have to function post-operatively. So these two things have to be taken care of. And like you said, IOL power calculation is always a tricky thing. And when you do cataract surgery, you don't always, get a 6/6 uncorrected 6/6 post-operatively. And you have to counsel your patients that you will still require aids, spectacles, etc. And you may not be unaided 6/6 even for distance.
I completely agree. But my point on toric IOLs was that suppose I do a toric IOL in a case of a corneal graft that does well for a few years and then reject for some reason. Then I do a regraft. That's a complete nightmare refractive solution for the eyes. So
Rajiv, can I just say something? Actually, there are certain conditions where I feel that we can do toric IOLs in post grafts, and there are certain conditions wherein I will be hesitant even if it's a clear graft. Absolutely. Now, a young individual with an absolutely clear graft and a full thickness graft, post PK, I will be a little hesitant in doing a toric implant. I will try to figure out other ways of handling the astigmatism. A person of, say, 60 years of age with an absolutely clear graft, if it's a full thickness or a partial thickness, I will go ahead with a toric implant, because the risk of rejection is higher at a younger age and lesser at older age, particularly somebody who is 60, having a graft for a long period, and the endothelial status is fine, endothelial count is fine, then I can go ahead and do a toric implant. A case of an anterior lamellar graft, wherein somebody has undergone an anterior lamellar graft and having a cataract, all sutures removed, I may go ahead with a toric implant because the risk of rejection will be much less in such case. And if it's a high astigmatism, then the patient will have a very poor quality of vision in these cases. So there are certain conditions wherein I will be, okay with doing toric implants, but there are certain scenarios wherein even if it's a clear graft, a young individual, risk of rejection is very high. Maybe I would try to figure out some other way of handling the astigmatism and do a monofocal lens.
End of the day, basically what I understand, and quite rightly said by both of you, is that we do a toric IOL in cases where we know the graft survival might be higher, where we know like a young individual or a high risk case where vascularizations are there. We may not choose to do a toric IOL because the chances of the graft rejecting is much higher. But then it comes in another scenario, and I have quite a few patients like this who have been operated, say, in the last 15, 20, 25 years, have been doing very well on a corneal graft and surviving well, but their specular counts are ridiculously low, like in their 400s. And they have a good amount of cataract and a very poor vision. Now, at this point of time, the patient is complaining of hazy vision, though the graft being very clear, but that specular microscopy report actually deters me from opening the eye altogether. Now, what would you do?
No, graft is clear, but specular microscopy is not so good. I think still step number 1 will be to do cataract surgery under viscoat, and then counsel the patients that we are doing it, but your graft may, get compromised, and then see how it goes. And then step would be to address the graft. So I feel that cataract if cataract is there, it has to be taken out. Sometimes what happens is that even if there is some amount of cataract and you're doing a graft, I think whenever you're doing a cataract surgery and you're doing a graft surgery, I mean, if there is even some amount of cataract with a graft, it's best to, address the cataract there and there only, because after the graft, the cataract is going to increase.
Now here come two perspectives. One is surgeon's perspective, the corneal surgeon who's done the graft. He knows that the graft may sink in and the graft may not survive. The second perspective is the true perspective, which is the patient's perspective that you can't see. So there becomes a clinician's dilemma, especially if you had been the operating surgeon for the graft.
Yeah,
that's very true. But if cataract is significant, you have to go ahead and do it. At this point of time, if somebody is having a high astigmatism, then what to do? That is again a question. Now, what I feel is that if a person is having a slow gradual reduction in endothelial count, then in that case, it's not a rejection that is causing any issue, right? So if that is not a very vascularized cornea, or if that is not having not a very young individual, I would still go ahead and think of doing a toric implant if the astigmatism is high, because in such a case, I may do an endothelial keratoplasty in future. So that is a kind of a plus minus kind of a situation wherein you may consider or may not consider. Both ways. It also depends on the comfort level.
So Rajiv, I think what essentially comes out of it is that if you're doing lamellar grafts, whether anterior or posterior, chances of rejections are much less. So you can go ahead and still do your, toric implants. But if you're doing a full thickness graft in a young patient, then you might be a little, skeptical about it. Ellen, what do you say?
Definitely, ma'am. I agree with you. Like what Dr. Rajesh was telling, anterior grafts, DALC, definitely we can go ahead with the toric IOL. Penetrating keratoplasty in an older patient, definitely would prefer still to go with a toric IOL, provided the surface is smoother. There is at least the central part, it is smoother with regular more of a regular astigmatism. If it is an younger patient with a penetrating keratoplasty, maybe I would like to hold on.
One thing that I have tried, not entirely successful at all times, is wedge resections and relaxing incisions on grafts. They are a little tricky and unpredictable, but at times some grafts I have managed to do a cataract surgery without a toric IOL. Not in all eyes, definitely not in all eyes, but in some eyes I've managed to do a monofocal IOL, non-toric, by just correcting the astigmatism on the surface.
So any comment? Yeah, please.
I have one question for you, madam. The DSEC graft, I think one of them what you showed was a DSEC, which was done outside, and when you were doing it separated a little bit. What are the parameters for the phacoemulsification you had in that? And I mean, you have a intraop OCT, but almost 95% of us outside don't have that. Any other thing how to find out, or better to put a air and leave it off? What is your suggestion?
Oh, best to put a, I would say, after doing so many of them, I would say, and after watching so many DSECs also, sometimes, when you even hydrate the wounds at the end of the DSEC, the graft starts to move, which you can appreciate on the intraop OCT microscope, but you can't do otherwise. So I would suggest that even when you're doing cataract surgeries, and you like very rightly said, you should leave an air bubble so that there's some amount of tamponade there, at least for some time. Then you may, burp it a little. So that is definitely there, and the parameters all have to be on the lower side. Even in the post-PK DSEC graph, which moved and which I showed, the parameters were on the higher side. And I knew it that the parameters were on the higher side. So you could, make out with the irrigation aspiration also. But your parameters should all come down on a little lower side.
Just slightly continuing it, whatever all these days we were seeing was with DSEC grafts. DMEC, have you seen any DMEC in graft inside cataract has developed later? Any suggestions on that? How to go about?
I've not done very many, but I've done 2 such eyes. And important thing is that you have to use viscoat there, because viscoat will stick the graft to the back of the recipient. And whole cataract surgery or whole phacoemulsification has to be done by the I call it, that's what I thought, like a visco. You used to have a soft shell technique, like a visco shell technique. So everything has to be viscoat only, and then underneath that you can get away with it. It doesn't move.
Yes, ma'am. Thank you.
Any other comment from any of the panelists? So if there are no comments, then maybe we can conclude now. So at the end, I would like to thank all the speakers who spared their valuable time and spoke very well, showed some very interesting videos, a lot of learning, a lot of teaching, a lot of new ideas and tips that came from those videos. I would also like to thank all the panelists who have contributed immensely in the discussion. And of course, I would like to thank the staff, Mr. Anil Kumar and Bhageshwar, for helping us to do this event, and our sponsor company IPCA for supporting the website. And in the end, once again, thank you very much. Thanks to all of you. A very good night to all of you. Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.
Bye-bye.
Thank you, Rajesh, and thank you, everyone. Thank you so much.
Special thanks for the last minute presentations.
Yeah.
Thank you, everybody. The videos